All right, my clock says 9:41. So I'm going to go ahead. I'm going to take a moment to introduce our two speakers today. We have Jacek Soroka, who graduated with a master's degree in theology from the Pontifical College of St. Bonaventure in Rome, Italy. Did postgraduate studies in spirituality at Antonianum University in Rome, and received his PhD in palliative care research at the School of Health and Medicine, Division of Health Research in Lancaster University in the UK. Currently, Jacek is a hospice chaplain, spiritual research coordinator, and assistant professor of palliative care at Mayo Clinic. He focuses his research on death awareness, the spiritual phenomena of the dying process, and caregiver experiences of caring for patients under hospice care in the home setting. And his partner today is Dr. Greg Kutcher, who's a family physician. He received his medical training from the University of Minnesota, practiced for many years in Mankato. He was also the CEO of the Mayo Clinic Health System in Minnesota and a hospice medical director in the Mayo Clinic system in Southwest Minnesota. He believes in order to improve our health and medical care, we must put a high value on our well-being, not just at end of life, but throughout our journey. So today, these two gentlemen are going to talk to us about terminal delirium in hospice and the caregiver perspectives while providing care to terminally ill patients in the home setting. I will let the pair of you take it away.
Thank you very much, Marty and Andy, for having us with you this morning. We are very, very honored, both Greg and I, and we are very privileged to spend those few minutes with you talking about delirium. So thank you for inviting us. We'll be talking about the study that we conducted with the caregivers of those who care for a dying patient with delirium. We published the study. If you need more information, you can find it in the American Journal of Hospice and Palliative Medicine. The background for this research was that although there is tons of information, lots of knowledge about what terminal delirium is and how to deal with it, a little is known about the experience of those who provide direct care at home. And we specifically wanted to focus on patients in the home setting because obviously they do not have support like everybody else does when they reside at the nursing home. When we have our loved one who is experiencing terminal delirium and falls to the floor, it is us who need to pick them up. We do not have anybody to call and say, staff, or ring the bell and asking the staff to help us. So it's much different. So we wanted specifically to learn about those experiences because really there is not that much information about what those caregivers go through, how difficult it is, what they want, what they expect. So we really wanted to know more about those experiences. We wanted to know how we as hospice or palliative care providers can help them. How can we assist them? And we did the study also to learn basically what they want from us. What are their needs? We wanted them to tell us. So that's the reason behind that research, behind that study. And again, more information could be found in that article that was printed in the first slide. So Greg and I will be talking a little bit about the findings, the most practical things. I think what we found during the study. Some things are new that were very much interesting, but many of those findings you are probably aware of. So the greatest theme or most important theme that came from this study as a result was that the most challenging aspect of caring for a delirious patient is the lack of knowledge regarding how to respond to that abnormal delirium that patient experience. So those family members were telling us, my loved one, he or she is not him or herself. And now they see things, for example, right? They see the spiders on the wall, or they see that somebody is standing there, or they say that, okay, I'm ready to go, I want to go. They didn't know how to respond to it. They really struggle with that, saying, do I affirm that? Do I negate that? Or simply, how do I deal with that? Nobody told me how to prepare. Nobody told me how to respond. So I think it is very important for us clinicians to educate them, to guide them in that, give them the practical ideas how to respond when that situation basically comes up. So that was I would say, Greg, one of our main findings, right?
Absolutely. And now, I'll just, Jacek, why don't you kind of keep pushing forward, and I'll have some more color commentary toward the end. Okay.
Yeah. So understanding what delirium is, being able to recognize it is and know how to respond to it contributes to better coping and greater confidence. So what we found out is basically that our caregivers do not know much about delirium. They are not really prepared for it. They do not know what it is. And very often we prepare them about the dying process, right? We tell them what to expect, more or less, if the disease takes its normal course. This what you can expect during this hospice journey. But very often those caregivers told us that they didn't know about delirium. They were not educated, or perhaps there was something mentioned that something like that might happen, but they did not know about it. So it is important for us to stress and during our education time with them, preparation for the journey, to tell them that delirium might happen, what it is, how it will be expressed, how patient will behave, right? Telling them that if this happens, if he wants to go out, go somewhere, gets up all the time constantly, that this is just the result of that's what is happening. So we really need to be careful to educate them, to tell them more what to expect, not only about the dying process, but also about delirium. Another interesting finding that we found is that caregivers go better when they are affirmed in their role, and when the professional relationships exist between them and between hospice staff. So many of the caregivers told us that they feel more confident, more at peace, when the staff member perhaps told them, "You are doing a good job. I saw that you've done this. I saw you, or I observed you coping with the situation, and you have done such a good job." And many caregivers say that simply boosted their confidence, and they were not afraid, or they were ready to jump into the difficult situation. So I think that perhaps maybe we do not do that enough to affirm them, to tell them, no, you are doing a great job. Everything is going well. Even if this happens, even if the patient fell, it's okay, because you've done a great job. So that encouragement is really important, and I would stress all the clinicians to establish that relationship and to affirm caregivers in whatever they do. In order to be effective, our education about terminal delirium needs to be progressive, both in verbal and written form. As I mentioned before, typically at the beginning of the hospice process, at the admission, we do educate them and we tell them things they might remember, but it is such a stressful situation, and we bombard them with so many different things, and sometimes they simply do not remember. So it is important to have something in written, to have a booklet of flyers that would specifically talk about the delirium, because I believe this is one of the most distressing symptoms of the dying process. With everything else we can deal, we offer medication, people feel better. But when they see their loved one in such a difficult distress, when they see them as somebody different that they know, it's very distressing. So we need really to educate them, and we need to prepare them. Increased confidence and better coping depends on personal relationship with hospice staff. Again, I would stress that if we are able to create that relationship with them, I think the experience, that difficult and scary, dark experience, could be transformed into something meaningful. Many patients or caregivers tell us how wonderful it was when the nurse came and simply sat on the floor and talked with them. When the nurse came or aide came or whoever, and had that special bond between the patient. So seeing that, caregivers seeing that it helps them cope better. So again, it is really important for all of us who care, to provide care, to establish that relationship. So they do not only need us, come to them and tell us, okay, this is delirium, this is how it works, this is what to expect. We give them that brilliant scientific knowledge, but they also need something else. They need us to touch their shoulder and say, you are doing a good job. It is okay. We can show them that we understand the patient, that we have that special bond. Once they see that will help them in their coping. Another interesting finding, and I think we all know about this, is that the perception of the caregivers is that the medication really do not help that much with the delirium. Perhaps our theory is that perhaps maybe because of their fear of the over-medicating, we simply do not provide adequate doses of meds. That might be the reason, but their general consensus, the majority of people whom we interviewed say they didn't feel that medication was so effective. Another interesting finding that we found, that interventions that were meaningful and important to patients in the past have positive effect of delirium symptoms. So what we want to say is sometimes we try different things, right? Medication is not very effective. So we try to say, okay, let's invite music therapists, right? Maybe music will calm that my loved one, and maybe those distressing symptoms will go away. Maybe he will be or she will be more calm. And we found out that if music was not important to patient in the past, it will not help during the delirious process. Sometimes, in the chaplaincy, our clinicians say, we tried everything, so let's invite chaplain. Maybe the chaplain will come and do something, that spiritual support. Chaplain will not perform a miracle if faith and spirituality were not important for patient in the past. So I think we have to be careful. So let's do not offer something that was not important to patient in the past to help or alleviate those symptoms of the delirium. So what we found out, and again, this is just confirmation of many other studies, that delirious patients benefit from a familiar, quiet environment, suggesting that perhaps the best care might be provided in a familiar place and by those with whom they're familiar. We have found out, it kind of confirmed, that when they are in their room, in that familiar, quiet environment, patients cope better. So I think we have to be careful and try to stress that and educate the caregiver how important it is. From our studies, we also found some, not really we cannot generalize obviously, but we have found a few cases, for example, that the massage, when the massage therapist came and provided massage, that was helpful with those symptoms. We also found out that to some, changing the sheets, bed sheets, really was beneficial. So when the aide came and gave patient a bath and put the new sheets, that had some effect, and patient felt better. But the most important, I think, is to stress that familiar voice, familiarity is really beneficial to cope with those symptoms, and to sometimes, teach the caregivers that very often we do not have to deny what the patient is saying. No, you are not seeing this, or there's nothing on the wall, or other things, but just with our gentle voice, with the voice that you're familiar with, tell them, just trying to distract them, telling them it is Jane, I'm with you, I'm your wife, I'm touching you now, you are in your bed, we are in our home, and so on. So that has might have some effect on those symptoms. Caregiver also told us of what type of support they expect or they would benefit most, and they told us that something that is very concrete, very practical. We had, for example, caregivers telling us how beneficial and valuable was when their employer gave them time off and allowed them to work from home, or knowing that this person is going through this challenging state. They offer something very practical, so they can really focus on the patient. So, and finally, that it is really important for us to educate caregivers, but it is also important for us to educate the communities. Really, and I think this is a big thing for hospices that work in our communities, that we need to tell them what hospice is, what the end-of-life care is, but also about the delirium. So they could, other neighbors and those who are involved can recognize that and can help those who suffer from that. So these are the main things. Greg, any?
Yeah, let me just, so again, I just, a couple things. Jacek was the sort of the motor behind this study. He's got the research background, and I would just like to share a little bit about how the study was done and how impactful it is for the people doing the study. So there were 3 other partners on the study with us. And on a previous study that we had done on a different situation, I think I learned about the power of doing the interviews. So if nothing else, it's kind of life-changing to interview this cohort. So all of us did pretty extensive interviews in sort of a semi-structured fashion. So we had open-ended questions, and we had a whole list of questions we kind of wanted to get to. But actually, you ask just a few open-ended questions, and the caregiver would hit those topics, and they're all recorded. And then Jacek did the coding, which is a process of listening to all the interviews and reading the transcript, and then finding these themes. So a lot of the power of this kind of study has to do with the ability of coding, what's called coding, so my comment there is that I think it's a methodology that needs to be done a lot more, particularly in the world of hospice and palliative care. Second comment would be, and just looking at the chat boxes, I'm sure that the major themes here are none of surprise to any of you. You see this all the time. I think the power in it comes from then taking it and using it with your staff, with the nurses, the social workers, and everyone, and letting them know about the power of engaging that trust as soon as possible, and feeling they do talk about pain, but they probably don't talk as much about delirium as maybe they could. If you all know the data on cancer patients, most of them are going to get it. I love the comment about spirituality. We learned in a previous study that if we portray spirituality as not a religious venue so much, but as an enhancing tool, that more people are going to take a chaplaincy during the process, and sort of to get kind of that whole spiritual perspective into to have families and patients sort of consider that. Because there is an existential issue here that we all know the spaghetti diagram. Delirium isn't really one thing. It's multiple causation, the papers that are coming out now about how complex delirium really is. We're not going to have a physiologic solution for this anytime soon. So engaging the families in sort of the existential, think of all the other cultures that find meaning in visions and find meaning in and some of the symptom that we just call symptoms. Again, we don't know. I'm not telling you anything you don't know already. I'm just trying to give sort of a perspective. So those are kind of, I would want to add one little thing is I retired 3 years ago. So I've been able to read the literature a lot and comb the literature on lots of different things. I'm involved in different ways, but not on a front-end clinical basis. So with that, I sort of, those are sort of my comments, and let's see what else have we missed in the chat box.
One additional comment that comes to my mind is also that it's really important in our dealing with delirium and in general coping with dealing with our patients and families is to communicate with them that we are their companions. Sometimes they do see us as professionals and somebody with great knowledge, obviously, that we can help them. But I think it is really important for us to communicate in some way to let them know that I am with you, that we are in the same boat. And it's important, especially for me, that will be probably the topic on my next study, that is to communicate with them our own mortality, that we are all together in this, that I will die as well. This is not my time perhaps, but I am in the same boat. And it's really, I've noticed in my practice that when I'm able to do that, they feel better, that they cope a little bit better. So they do not see this dying really as it just affects me. Every entire world is going to do, and they do their own things. But this person who comes to me, my nurse, my doctor, my chaplain, whoever, they are mortal as well. And they recognize that, and that will kind of help us to create that relationship and improve coping.
I saw, Dr. Kutcher, you were looking at the questions in the chat.
Yes.
I think we kind of touched on most of them. There was one that said, are there support groups for people that are caring for people experiencing terminal delirium that is prolonged? I am not aware of any, but if any of you on this call are, that would be a super resource to share. Martin has a question, but he didn't put it in the chat.
I like to ask him out loud if I can. So I took some notes as you guys were talking, and I wrote down things like, how do we prepare them better? How do we move more upstream? And I know you guys on the hospice side are trying to help these patients prepare, but what about those of us that aren't? And so I work just on the inpatient side, but even though I do, I'm still preparing families who are going to be discharging with hospice. And usually I'm preparing them for certain physical exam signs that are going to change, that we know are distressing, that we know if they're caught off guard is going to be even more distressing. You think of like death rattles, like the classic example, but other physical exam signs too. I don't think I've ever talked to a patient about preparing for the possibility of delirium. And so is this something that we should be considering outside of the hospice realm that can help you guys help these patients so that way they're hearing it twice or getting more prepared? I don't know, how can we help from outside of the hospice world?
I'd love to hear what other people have to say, but to me, that you just nailed what's so incredibly important. My own hunch, it's such a broad topic. It's not only preparing people. First of all, yes, I think they need to have education right from the start. If you look at Fast Facts, the number one topic was always delirium. That was the first entry in Fast Facts. It wasn't pain, it was delirium. And so I think people just need to know about it. The more talking, the better. The second thing that my impression, certainly as a family physician and in my last 5 years as a hospice medical director, it sure seemed that patients that entered hospice early, particularly in terms of, say, cancer diagnosis, and sort of got off that treadmill early, it was pretty rare to have a serious chaotic delirium experience. We all know how traumatic that is, where you have somebody enters in hospice, they're in the last week of life, they're already symptomatic, they have terrible delirium, you try to take care of them in the home, the nurses are out there, the Haldol isn't working, you're trying to, is it pain, you know all that stuff, and then do we do the chaos of getting them back into the hospital, and then it gets worse because, we know all that. It didn't seem to me that when somebody had a longer term relationship with hospice, and by that I mean that's a proxy for them kind of thinking about their well-being earlier on. You didn't have these chaotic, it seemed to me a rare situation where you had these chaotic deliriums when it was done in so I think that it's not only just it's in helping people as they make decisions as about the disease treatment, as the disease treatment, as the benefits become less and the risk becomes higher, they need to know about the risk of delirium in a chaotic hospice transfer at the last bit. I know that's a little pie in the sky, but I think there's a huge opportunity there.
Yeah, because I always worry that I only have so much time with them, so I got to try to hit the highlights. But this seems like something that A, causes a ton of distress, and B, is fairly common, that it might be worth adding to, the elevator pitch that I give most of my patients that are leaving with hospice.
Absolutely. The research shows the majority of cancer patients will have it. So it's not so much a matter of if, it's a when question. So
so that education, when you do that at the hospital, when you educate that might happen, I think it's also important to stress that it is normal. That delirium's normal part of the dying process, like Greg said, it's frequent. It's so frequent. So the caregivers are prepared and they know, okay, so when this happened, it's not because my loved one is crazy or something is really, he's possessed or whatever, but it's just a normal part of the dying process. When we assure them about that, do not worry about it, or when you see this, or when you say that, do not panic. That's what we humans are. This is how we are created. This is part of us, and that can help also with education.
There was one question, just it was a direct message. It was about present an example of how you have presented spirituality, chaplaincy that has been effective in moving folks towards accepting the discipline. What we did, and Yasa could comment a little bit more, but what we actually did is we changed, we helped script. I don't usually believe in scripts, but in this case, we kind of helped when we opened up hospice cases, so the nurses and social workers, the language they used to ask about chaplaincy, we scripted that differently, so they didn't associate it so much with religiosity, and we found a higher uptake of chaplaincy in our cohort. So that was, Jacek, would you say that any differently?
Yeah, absolutely, because very often patients and caregivers are very much afraid when they think about the chaplain or about spirituality. They do connect it with religion. So we try to explain what's really how we understood spirituality and how different it is. That's basically saying that we all, as humans, are spiritual beings. We like it or not, but we are spiritual beings, but not necessarily that spirituality is expressed through religion. So communicating that to them and affirming and telling them, that chaplains or spiritual care providers, that are not pastors, or they will not try to convert you. They are not here to pray with you. Sometimes we even do not pray, or even do not say even a word, but we respond to those spiritual needs that are universal, that are human. And when they know that, they feel a little bit more comfortable with inviting spiritual support into their care.
All right, we are a little over time, but I just want to thank both of you so much. This is clearly a topic that is pertinent to all of us. So thank you for your research. Thank you for your time today. And if there are any additional questions, would you guys be okay with me forwarding them to you by email?
Absolutely. Yes.
Okay, so if any of you have additional questions, feel free to email them to me, Andy Vandermolen at aah.org, and I will get them to these two gentlemen. And with that, thank you all and have a good rest of your day.
Thank you
Thanks
so
for
much.
having us. Thank you.
Bye. Bye.